Welcome to a new episode of Neomed AI Podcast, the podcast that offers insightful AI for better neonatal care. Today we're focusing on intraventricular hemorrhage, or IVH, in very preterm babies. We'll start with the basics, what it is and why it happens, then move through prevention and management, and finish with some of the complexities, such as post-haemorrhagic ventricular dilatation.
IVH is one of the most challenging complications we face with extremely preterm infants. Even as survival has improved, brain injury remains a major source of disability, so understanding IVH is essential.
To begin, could you explain what intraventricular hemorrhage is and why it affects preterm infants?
IVH is bleeding into the brain's ventricular system. In preterm infants, it usually starts in the germinal matrix, a layer of fragile blood vessels and developing cells under the ventricles. In term babies, this region has mostly disappeared, but before about 32 to 34 weeks, it's still present and vulnerable. Its vessels lack supportive structures, fewer pericytes, thin walls, and limited astrocytic support, so they can rupture easily when blood flow fluctuates. Preterm infants also have immature systems to regulate cerebral blood flow, so things like low oxygen, high carbon dioxide, fluctuations in blood pressure, or even routine handling can cause swings that lead to bleeding. Many risk factors contribute. The smaller and younger the infant, the higher the risk. Infants born under 28 weeks or weighing less than 1 kilogram are especially vulnerable. Male sex, systemic infections, respiratory distress, and exposure to inotropes all increase risk, whereas completing antenatal corticosteroids and magnesium sulfate helps reduce it. Most IVH occur in the first 72 hours after birth, often within the first day.
That gives us a solid foundation. Let's make this practical. Imagine a 28-week baby boy weighing about 1.1 kilograms. Mum received antenatal steroids, but no magnesium. Cord clamping was delayed, and he's on CPAP, stable and warm. How would you assess his risk, and what steps would you take?
His gestation and weight put him at moderate to high risk, and he didn't receive magnesium sulfate, which has neuroprotective effects. We'd monitor him closely. Routine cranial ultrasound scans are done in the first week for babies under 32 weeks. Regular head circumference measurements help detect early ventricular enlargement. We practice gentle care, cluster procedures, handle him minimally, and maintain normothermia. We manage his ventilation carefully, avoiding swings in oxygen and carbon dioxide, and we keep his head midline and slightly elevated to support venous drainage.
You mentioned antenatal interventions like steroids and magnesium. Could you summarize why they're important and when they should be given?
Antenatal steroids are recommended for women at risk of preterm birth between 24 and 34 weeks. They improve lung maturity and reduce risks of IVH and other complications. Magnesium sulfate is given when preterm birth is imminent, usually up to around 30 weeks. It protects the fetal brain and reduces the risk of cerebral palsy. These interventions, along with delayed cord clamping for at least 60 seconds, are simple yet powerful ways to protect the brain.
After birth, what strategies help reduce the risk of IVH during respiratory and circulatory management?
We favour non-invasive ventilation when possible. If intubation is necessary, we use volume-targeted ventilation to deliver stable tidal volumes and avoid sudden changes in carbon dioxide. Oxygen saturations are kept in a narrow target range to prevent hyperoxia or hypoxia. Circulatory management focuses on avoiding rapid fluid boluses and treating hypotension based on the baby's clinical status rather than numbers alone. Avoiding dramatic shifts in blood gases or blood pressure helps protect the fragile germinal matrix.
There's been a lot of talk about neuroprotective bundles. What do they involve and how strong is the evidence behind them?
Neuroprotective bundles combine several low-risk practices. We keep the baby's head in the midline, tilt the incubator slightly, cluster care, provide adequate analgesia, and avoid unnecessary suctioning or flushing lines rapidly. Evidence for individual components is limited. Trials on head positioning haven't shown clear benefits, but collectively these measures help reduce stress and fluctuations. They're straightforward and safe, so most units use them. The key is consistency.
Let's pause and talk about classification. I often hear about papille grades, but there are also modifications. How do we interpret these grades, and why does it matter?
The papille grading system is most commonly used. Grade 1 hemorrhage is bleeding limited to the germinal matrix. Grade 2 occurs when blood enters the lateral ventricles but doesn't cause them to enlarge. Grade 3 is when the ventricles are filled and distended by blood, leading to hydrocephalus. Grade 4 involves bleeding into the brain tissue around the ventricles, often with venous infarction. Some modifications distinguish between pure parenchymal hemorrhage and periventricular venous infarction. Understanding the grade helps us counsel families about prognosis. Lower grades generally have better outcomes, whereas grades 3 and 4 carry higher risks of cerebral palsy, cognitive impairment, and epilepsy. It also informs how intensively we monitor for complications like post-haemorrhagic ventricular dilatation.
How do you perform and interpret cranial ultrasounds? What should clinicians look for in week 1 versus later scans?
Cranial ultrasound is our primary tool for detecting IVH and monitoring ventricular size. In week 1, we scan through the anterior fontanelle using coronal and sagittal views. We look at the germinal matrix for echogenic areas suggesting a bleed and assess the choroid plexus and ventricle structure. On later scans, we focus on ventricular size. We measure the ventricular index, the distance from the midline to the lateral wall, and compare it to normative charts. We also measure the anterior horn width and thalamo-occipital distance. We evaluate brain parenchyma for echogenic lesions that could represent venous infarction. As the infant grows, the ventricles naturally enlarge, so we use gestational age-specific reference values. If we see increasing measurements or a rapidly expanding head circumference, we alert neurosurgery.
Returning to our case, suppose his day 3 scan shows a small grade 1 bleed. How would you reassure the parents and plan the next steps?
Grade 1 IVH is confined to the germinal matrix and usually carries a good prognosis. I'd reassure the parents that most babies with this finding do well. We'll rescan again in 1 to 2 weeks to ensure it doesn't progress. Meanwhile, we continue neuroprotective measures and gentle respiratory support. We also encourage parents to engage in kangaroo care when the baby is stable, which can improve bonding and reduce stress for both the infant and the parents.
And if the bleed progresses to grade 2, where blood has entered the ventricle but hasn't caused dilation, do you change management?
Generally, no. Grade 2 bleeds often stabilize without intervention. We remain vigilant, continue careful ventilation and monitoring, and repeat ultrasounds to track any change. We only consider intervention if the ventricles begin to enlarge or if the baby shows clinical signs of rising intracranial pressure, like a bulging fontanelle or apnea.
Some units in the US use prophylactic indomethacin to prevent severe IVH. How does practice differ in the UK and why?
Studies show that prophylactic indomethacin can reduce severe IVH, but it doesn't improve long-term developmental outcomes and can reduce blood flow to the brain, kidneys and gut. In the UK, we generally avoid giving it prophylactically and reserve it for treating a significant patent ductus arteriosus. We prioritise antenatal steroids, magnesium sulfate, delayed cord clamping and gentle postnatal care. Other agents like vitamin E or phenobarbital haven't been shown to be effective and may cause harm.
What about other supportive measures such as caffeine or vitamin K? Do they play a role?
Caffeine is used primarily to treat apnea of prematurity. Some evidence suggests it might reduce the risk of IVH when started early, but its main benefit is reducing the need for mechanical ventilation. Vitamin K is given to all newborns to prevent bleeding disorders, and it's critical because preterm babies are at risk of vitamin K deficiency. It doesn't directly prevent IVH, but ensures proper clotting.
Now, let's tackle a more complicated situation. Suppose a baby develops a grade 3 IVH with ventricular dilation. The ventricular index crosses the 97th percentile, and the anterior horn width and thalamo-occipital distance are enlarged. His head circumference is riding and his fontanelle is tense. What is happening physiologically, and when should you intervene?
Grade 3 IVH means the bleed has filled and distended the ventricles. The dilation occurs because blood clots block the normal flow and absorption of cerebrospinal fluid, causing it to accumulate. This leads to PHVD. As the ventricles enlarge, pressure increases and can damage surrounding white matter. We measure ventricular size using ultrasound indices. When they exceed the 97th percentile and there are clinical signs like a tense fontanelle or rapidly increasing head size, we discuss intervention. Options include serial lumbar punctures, placing an external ventricular drain, implanting a ventricular reservoir for intermittent tapping, or creating a ventricular subgaleal shunt. Lumbar punctures are simple but rarely sufficient alone. Drains provide controlled, continuous drainage but carry infection risks. Reservoirs and subgaleal shunt allow less intensive management but still carry risks. Each case is discussed with neurosurgery. Early drainage may reduce brain injury, but evidence is based on small studies. Decisions are individualized and involve the family.
If these temporizing measures don't stop the hydrocephalus, what happens next?
If PHVD progresses despite temporizing measures, a permanent ventricular peritoneal shunt may be placed. This surgery diverts cerebrospinal fluid from the brain to the abdomen, where it's absorbed. We usually wait until the baby is nearer term and more stable. About half of infants with significant PHVD eventually need a permanent shunt. Shunts improve survival and quality of life, but require long-term follow-up because they can malfunction or become infected.
And how do you counsel parents when a baby develops a grade 4 IVH with parenchymal involvement? These are especially heartbreaking cases.
Grade 4 IVH involves bleeding into the brain tissue and carries a high risk of severe neurological impairment. We discussed the extent of brain injury and likely outcomes with parents and the multidisciplinary team. Some infants may survive with profound disability, others may not survive regardless of intervention. Our goal is to provide clear information and compassionate support, and to consider the infant's best interests. Occasionally, families choose palliative care. These decisions are among the hardest we face.
Are there maternal conditions or exposures that increase the risk of IVH, which we haven't touched on yet?
Yes, maternal conditions like chorioamnionitis, placental abruption, and preeclampsia can contribute to IVH risk. Chorioamnionitis leads to inflammation and cytokine release that can damage the fetal brain. Placental abruption can cause acute asphyxia, leading to fluctuations in cerebral blood flow. Preeclampsia is associated with abnormal placentation and can lead to fetal growth restriction, which increases vulnerability. Maternal drug use, including cocaine and certain anticoagulants, can predispose to intracranial bleeding. Proper antenatal care, treating maternal infections, and managing hypertension help mitigate these risks.
Pain and stress can destabilize these infants. How do you manage pain and discomfort to protect the brain?
Pain management in preterm infants is critical. Even minor procedures like heel pricks or suctioning can trigger stress responses that increase blood pressure and intracranial pressure. We use non-pharmacological measures first: swaddling, nesting, kangaroo care, and non-nutritive sucking. Oral sucrose or expressed breast milk given just before a painful procedure provides analgesia by triggering endogenous opioid pathways. For more invasive procedures, such as insertion of a central line or ventilation, we use appropriate sedation and analgesia, balancing pain relief with the risk of respiratory depression. Recognizing and treating pain early prevents stress-related blood pressure swings that could precipitate IVH.
Earlier you mentioned international differences. Could you outline how approaches vary outside the UK and why?
In North America, it's more common to use prophylactic indomethacin in extremely preterm infants. Some centers believe the reduction in severe IVH warrants the risks. In Australia and New Zealand, practice varies. Some use prophylactic indomethacin or ibuprofen, whereas others follow a more conservative approach similar to the UK. There are also differences in how aggressively units pursue intervention for PHVD. Cultural attitudes toward risk and resource availability influence these differences. Despite variation, we all share the same goal: reducing brain injury and improving outcomes. International collaboration and standardized guidelines may help harmonize care.
We've discussed the acute phase, but what about neurodevelopmental outcomes later in childhood? How often do survivors of IVH experience learning difficulties or behavioral issues?
Survivors of severe IVH are at high risk of neurodevelopmental impairment. Cerebral palsy rates can range from 20 to 50% depending on hemorrhage grade. Cognitive impairments such as attention difficulties, executive dysfunction, and learning problems are common. Even children without overt motor deficits may experience subtle cognitive or behavioral challenges that become apparent when they reach school age. Some develop epilepsy or sensory deficits like hearing loss. Early and ongoing assessments combined with targeted therapies can mitigate some of these difficulties. Parents should be prepared for potential educational support and psychological counseling as their child grows.
Supporting families emotionally must be a huge part of the job. What resources do you recommend to parents navigating this journey?
It's vital to recognize the emotional toll on families. We encourage parents to participate in care because involvement improves bonding and confidence. Many units have parent support groups where families can share experiences. National charities offer information and counseling. In the UK, organizations like Bliss provide resources and advocacy. Psychological services are increasingly integrated into neonatal follow-up clinics to support parents dealing with anxiety, depression, or post-traumatic stress. Nurses, social workers, and therapists all play a role in guiding families through the NICU stay and beyond.
Looking to the future, what research areas hold promise for improving outcomes in IVH?
Better monitoring tools, such as near-infrared spectroscopy, may allow earlier detection of instability or bleeding. Anti-inflammatory agents and therapies targeting the germinal matrix are being explored. Stem cell therapy is an exciting but distant possibility. Randomized trials evaluating when to intervene in PHVD would be valuable but are difficult to conduct. Overall, improving our understanding of brain development and injury in preterms will guide better preventative and therapeutic strategies.
Finally, can you summarize the top takeaways for clinicians?
First, prevention is critical. Antenatal steroids, magnesium sulfate, delayed cord clamping, and delivering in a tertiary center. Second, provide gentle, stable care after birth. Avoid fluctuations in blood gases and blood pressure. Use volume-targeted ventilation when needed. Keep the head midline and elevated, and cluster care. Third, monitor vigilantly. Perform routine cranial ultrasounds, measure head circumference, and involve neurosurgery early when the ventricles enlarge. And finally, involve families in decisions and provide long-term support.
Those are excellent reminders. Before we close, let's run through a few quick scenarios to reinforce some key points. Ready?
Ready.
Scenario 1. A 30 plus 5 week baby with a grade 1 bleed. What's the outlook?
Very good. Grade 1 bleeds often resolve without long-term issues. We continue routine care and follow-up.
Scenario 2. A 29-week infant on a ventilator develops a grade 2 bleed. How do you manage?
We continue volume-targeted ventilation, maintain stable gases, minimize handling, and monitor. We intervene only if ventricular dilation develops.
Scenario 3. A 25-week baby shows rising ventricular measurements, and parents are unsure about early drainage. What do you say?
We explain that early drainage may reduce brain injury, but isn't conclusively proven. We outline the risks and benefits of each option, involve neurosurgery, and respect the family's wishes, while emphasizing close monitoring.
Scenario 4. The team asks about giving indomethacin prophylactically to prevent IVH in a 26-week infant. What's your view?
We don't use indomethacin solely to prevent IVH in the UK. We reserve it for symptomatic PDA and focus on other neuroprotective strategies.
Scenario 5. A baby with a significant patent ductus arteriosus is desaturating frequently. Should you treat the ductus to help with IVH risk?
If the PDA is hemodynamically significant and contributing to cardiopulmonary instability, treating it can improve overall stability and may indirectly reduce IVH risk, but we treat it for its cardiovascular effects, not primarily to prevent IVH.
Beyond acute management, what long-term follow-up should families expect after a baby survives IVH?
These infants need developmental follow-up. We arrange neurodevelopmental assessments at 3 to 4 months corrected age, 12 months and 2 years, with further reviews in childhood. We involve physiotherapy, occupational therapy, speech therapy, and developmental pediatrics. Hearing and vision assessments are repeated. We monitor head growth and watch for signs of hydrocephalus if a shunt is in place. Support for families is essential. We connect them with community services and support groups.
Are there ways for parents to reduce the risk of preterm birth or IVH in future pregnancies?
Parents can work with their healthcare providers to manage health conditions, avoid smoking, treat infections promptly, and attend regular prenatal care. Women with a history of preterm birth may benefit from progesterone therapy or cervical cerclage. Early use of steroids and magnesium in a subsequent preterm labor remains key for neuroprotection. Delivering in a center with specialized neonatal care also makes a difference.
Thank you for walking us through all these facets of intraventricular hemorrhage. It's been a thorough and enlightening discussion.
Thank you for having me. I hope this conversation helps clinicians feel more confident caring for these vulnerable infants and supports families navigating this journey.
And thank you to our audience for tuning in to the Neomed AI Podcast. We look forward to sharing more neonatal topics with you next time. Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.